Welcome everyone. Hi, it's Angela with Lactation Education Resources and my colleague Sekeita Lewis-Johnson.
Yes, welcome everyone. Good morning, good evening, good afternoon, all of the above.
All of the above. So nice to see everyone. Thank you so much for attending today. We are going to be talking about exam prep.
Yes.
Many of you are taking the exam in just a few weeks, right, Sekeita? Oh my goodness.
Wow, time flies, right?
Indeed it does, and especially during the times of COVID. So, but breastfeeding is still happening all around the world, so we're here to help you to pass that exam. I am someone who has worked in the community for over 30 years, and I also have served on both the IBLCE Board of Directors as well as the ILCA Board of Directors. The IBLCE is the organization that creates the exam, and ILCA is the professional organization for the profession. How about you, Sekeita?
Well, currently I am the lead nurse planner for LER. I also served on I actually am currently serving on the board of the United States Breastfeeding Committee. I have over 20 years in maternal health as a nurse and about 12 years as a lactation consultant, and that is a board certified IBCLC. So I'm excited to be here, excited to share my knowledge with you in hopes that you will be successful on your exam and in practice.
Okay, so ground rules. Please do not photograph or record this information with a camera, phone, or other equipment. We are recording it, and you will be able to review the lessons as many times as necessary. And a few of your questions will be answered during the session by Julie and Kim, so they're just going to put it, they'll respond right in the question box as they are IBCLCs, and they will flag other questions which will be asked by, if several of you are asking the same question, then they're going to flag those questions and we'll be able to answer them at the end of the session, even if it means that the session is longer than an hour and a half and maybe even closer to 2 hours. So we will have the recording up on our website as well as on YouTube within the next few days. So, Sekeita, would you like to take it away and chat about medications?
Absolutely. Thank you, Angela. Thank you so much. So before diving into medications, I want to start off with a couple key points to notice so that you can calm your nerves just a little bit. So the medication portion is not intended to be a pharmacology test. So keep in mind that the exam is geared toward the novice, which is entry-level information. So I'm going to go over some key points that keep in mind, and keep in mind as you apply them to your knowledge base. So not just for memorization, but also for application in practice, should you see a question related to any of these things. And so just to kick it off, keep in mind also that the amount of drugs that goes into the milk is dependent on several factors. And the factors I'm going to list, just keep these in mind. In your handout, you will also receive, this is in that handout, so you'll have that. So just listen closely and please ask any questions if you need clarification. But the milk to plasma ratio is useful to evaluate the concentration of medication in the plasma compared to milk, meaning blood. Plasma is a blood product. Excuse me. So that is, excuse me, that's what the milk to plasma ratio is. The relative infant dose is a very important clinical parameter to determine safety. It is usually expressed as a percentage of the maternal dose. So according to HELS, and HEL, I mean medication in mother's milk, medications with a relative infant dose that's less than 10% is considered relatively safe for a full-term infant. So if the relative infant dose is greater than 10% for a full-term infant, you should probably use caution, and further assessment of the situation is warranted. So when we talk about further assessment, we're going to go into oral bio availability, which refers to the ability of a drug to reach the circulation after oral intake, meaning circulation in our bloodstream. Drugs with a low oral bioavailability are generally poorly absorbed in the infant's GI tract, and they are destroyed in the gut or taken up by the liver before entering into the infant's system. So keep in mind that medications that enter the milk compartment, they enter the milk compartment from the lactating person's blood, right? So that's remember that during the colostrum phase, medications transfer into the milk easily. However, the total dose transferred to the infant is low due to the limited milk volumes. Next slide. So give me just a moment. So the key points to remember that most drugs enter at really small levels, at clinically insignificant levels. Clinically insignificant means that they really won't harm. However, you determine the level of risk regarding the lactation risk category, the levels in the milk, and the relative infant dose. And be cautious of high vitamin doses. Also, you think about sedatives, opioids, radioactive agencies, anti-cancer drugs, and high doses of iodine. All of these drugs should be avoided. Next slide, please. So remember that drugs may transfer into the milk in high concentrations in the lactating parent's plasma. So those with low molecular weights, less than 800 Daltons, low molecular weights will transfer. High molecular weights will not. So lower than 800 Daltons. Medications with low protein binding and those that pass into the brain, those are the ones that can impact milk. I'm having a moment here. Oh, hold on. Let me pause.
Well, that's a lot of information there. That's a lot of information right there.
Sitting here like, okay, I need to slow down a little bit. Just remember, it's always safe to check your resources and to choose medications, particularly when we think about the properties of the drug, drugs that have short half-lives or have high protein binding, low oral bioavailability, and or high molecular weights. All of this is on the slide. I am sorry, I just had a brain pause for some minute. And so if you need clarification, please don't hesitate to say, Sekeita, what was that? In the chat, and I will get back with you. Next slide, please. So we're going to move on to antibiotics, and antibiotics they're commonly prescribed for almost everyone, but particularly for lactating people and breastfeeding mothers, they usually will often call and have questions about, is this safe? So as a rule, antibiotics are typically safe to take. Notice though, if you look at this chart, I've listed the L category on the far right. That category are categories that HAL categorizes as the lactation risk. So L1 being the lowest and L5 being hazardous, don't take. In saying that, I don't want you to get caught up and remember all of these L numbers. That is not why this chart is like this. This chart is put forth as a reference for you now and later in practice. So Cipro is one to note. It is an L3. The reason why I noted Cipro is because it can be associated with GI problems for the infant. So you want to choose a different antibiotic and for the person taking it. But again, as a rule of thumb, antibiotics are typically safe. So if you look at this chart, you can look, most are L1s and L2s, and the bottom two listed are L3s. let's see, if you're not familiar with many of the drugs, it may be helpful to know that most antibiotics end in CIN or as an ampicillin. That's not true for all, but many of antibiotics end in like penicillin, ampicillin, those types of things, gentamicin. So keep those in mind. But the biggest concerns for infants would be changes in the gut flora and antibiotic resistance. So those are key things you want to keep in mind. Next slide, please. Moving on to antifungals. Antifungals is another anti-infective, but it is for fungus. These drugs are commonly used for yeast, or some people may hear thrush. Thrush is an oral infection. So not sure if there will be questions on the exam, but keep in mind that both the mother and infant should be treated simultaneously if they need to be treated for thrush or yeast, as that can pass back and forth readily. So topical antifungals such as nystatin or mitaconazole are used to treat yeast and are considered safe as long as minimal amounts are applied to limit the oral absorption by the infant. Clotrimazole, I hope I say that correctly, has been implicated in contact dermatitis and should be avoided if possible. However, HEL does have it listed as an L2. Next slide, please. So analgesics is pain medicine. Pain medicine is common almost on after birth, almost for everyone. There are a few folks who are naturalists and won't take any postpartum medications, but for the most part, pain medicine is generally something that is taken. Tylenol is an L1, so when you look at the categories, but codeine is an L4. So I know some folks who work in the medical field, and sometimes even if you don't, you might see Tylenol 3, Tylenol 4. That the 4 or the 3 indicates how much codeine is in it. In any event, codeine is an L4, which indicates that it's possibly hazardous. The FDA came out a few years ago and said, you know, that this medication should not be taken by lactating individuals, because there are a few people with the genetic trait that makes them very rapid metabolizers of codeine. So with that being said, if you're a rapid metabolizer and that medication is in the milk, broken down extremely fast, the infant may get a large dose. And so when you look at the right side of the screen, it says concerns for sleepiness or poor feeding. That is the biggest concern. Sleepiness and not waking to feed could be detrimental. So the FDA and numerous drug advisory groups recommend that codeine no longer be used during lactation. Motrin is a non-steroidal anti-inflammatory and it's classified as an L1. Motrin is also, the other generic name is ibuprofen. Aspirin. You don't want to use aspirin when the infant is sick or have a fever because it is associated with Reye's syndrome. Morphine is classified as an L3. It is usually used during cesarean sections. It's placed in the spinal cavity, and sometimes it's used for postpartum surgical pain management. And it appears to be safe for limited use. So L3 meaning short term, use caution. Whenever you see an L3, just really check out all the specifics because morphine is an opiate. And so all narcotics, it falls into that narcotic range. All narcotics should be used for short time frames. And please note that the safety of medications listed above is that if they are prescribed. So sometimes there is medication abuse, which means that then we fall out of the safety parameters, if that makes sense to you. Next slide, please. So seizure medications. These seizure, a lot of times, working in maternal child, people would always say that person's on max sulfate, they can't breastfeed. Well, if you look at magnesium sulfate, which is at the very bottom of the screen, it is classified as an L1. And Lamotrigine, Lamictal, is classified as a L2. That is an option for someone who has a seizure disorder and wants to continue to lactate and provide milk. Lamictal is an L2. There are other medications. Depakote we should avoid. Topamax, you want to inquire, and there will be some close monitoring. But what are the concerns? The concerns for the infant is sleepiness, poor feeding, and irritability. And so those are key things to, if someone is on Lamictal, key things to educate about, particularly regarding the infants, monitoring the infant and the infant states, alertness states. Next slide, please. So you see 3 antidepressants listed here, and there seems to be sometimes a lot of debate about antidepressants, but these 3 antidepressants appear to be safe for breastfeeding and lactating folks who are experiencing various levels of postpartum depression. It's certainly better for someone to be taking L1, L2 medication than to be depressed and by putting baby in jeopardy because of, and I don't want to even say depressed. There are also postpartum mood disorders that can happen and that antidepressants are prescribed for. So some of the concerns for the infant in this state would also be sleepiness, poor feeding, low muscle tone, agitation, and withdrawal symptoms if the infant was exposed during the pregnancy, meaning the person was taking the antidepressant during pregnancy. Next slide, please. Antihypertensives, another way to say this is blood pressure medications. So generally speaking, you can be in you can have hypertension and still take a medication that can assist with that while protecting breastfeeding. So again, don't put too much stock in looking at the names, the drug names, the common names. You don't need to do that. I do want to call your attention though to the asterisk at the very bottom. That drug, Lasix, furosemide hydrochlorothiazide, which is also hydrodiaryl, got that one right. Those have the potential to reduce milk supply because they are called a diuretic. So diuretics usually get the fluid off of our bodies. So those are two to be familiar with, and just the potential to reduce milk supply. However, look at the infant monitoring. All of them pretty much are the same. And so I want you to take note of, if it says infant monitoring, what should you monitor the infant for? Usually it's sleepiness, lethargy, pallor, poor feeding, low muscle tone. All of those seem to be consistent. And so that's why I said don't get too caught up. This is an entry-level exam. These are some terms that I want you to remember, and I want you to remember this key term about medication is that, again, remember, most medications are safe, and keep that lens whenever you read a question. Make sure you see what the question is really asking you. Next slide, please. Okay, general rules for vaccinations. They're generally safe. However, smallpox and yellow fever. Yellow fever vaccine is not recommended. Smallpox, according to Lawrence, the smallpox vaccination is inadvisable for the mother of an infant younger than 1 year of age, nursing or not. The personal contact, not the breastfeeding, causes the risk. Therefore, no advantage exists to weaning if vaccination is necessary. This vaccination is not given routinely and is rarely indicated. All right. I think that covers, Angela. Did you want to mention something about the chicken pox, the varicella vaccine? Because we were just discussing that, and I didn't take note of that, but I want you to chime in, and I want you to add anything that I may have forgotten during my little mind mishap.
No, let's, so just two quick things. One is the varicella. The issue with the chicken pox is an issue, actually come back, Sekeita, because we've got a question for you. So the onset of maternal chicken pox, the issue is if it occurs in the antepartum or postpartum period. And so that's the question. If the parent is infected, isolate until the parent is no longer clinically infectious. If seriously ill, treat with acyclovir. The infected mother's infant administer the varicella zoster IG to neonates born to mothers with an onset of chickenpox less than 5 days before delivery, and isolate separately from the parent. Send home with the parent if no lesions develop by the time the parent is non-infectious. And for other mothers and infants, send home at the earliest date. The varicella zoster IG may be given to exposed neonates. And so really with chickenpox in particular, the usual recommendation is as long as there are no lesions on the breast, it's okay for direct breastfeeding to continue. If the chickenpox lesions are close, or if the child would touch them, then you want to cover them. But the bigger issue is in that postpartum and the antepartum and that postpartum period. So like in those few days, antepartum or postpartum. So just want to make note of that. The varicella vaccine is compatible with breastfeeding, so that's not necessarily an issue. Somebody had a question though about whether or not mag sulfate is compatible with breastfeeding. What do you think?
It absolutely is compatible. It is an L1. It is safest. Yes, it is. And that's important. I want to say that that's extremely important because mag sulfate is one of the drugs that's used to treat preeclampsia. And I'm saying that because the books and theory used to be that in order to treat preeclampsia, you deliver the baby, but you also use mag sulfate. Now we know that after delivery, you can develop preeclampsia. So sometimes folks are readmitted after delivery into the hospital setting, and they're put on magnesium sulfate to prevent them from becoming eclamptic, which is a seizure disorder or seizure-like activity. I shouldn't say disorder. So with that being said, magnesium sulfate is absolutely safe. Sometimes in the instance where, and this is not related to the exam, but just to give you an idea of why this might pop up, or it could be, I don't know, but a person is readmitted to the hospital and then put on magnesium and they're still lactating. They've been exclusively feeding their infant and they want to continue to do that. That is perfectly safe. Sometimes infants have been allowed back in, but during the pandemic, I don't think that probably is an option, but it is an option to protect that milk supply and send that milk home to infants. So just saying, yes, magnesium sulfate is 100% yes.
Excellent. Thank you so much. Thanks.
Now, yes.
Yes, exactly. And for what may be on the exam. So.
Yeah, exactly.
Good. Okay, thank you so much. Okay, so now we're going to move ahead and I'm going to talk about breastfeeding beyond the first month. So I've worked in both the hospital as well as in private practice. And the reason why we're going over breastfeeding beyond the first month, and we did medications first, we're going to do a couple of other topics, and then we're going to have some questions for you that you can answer yourself, and we'll put some polls up. And then we're going to give you some ideas in order to get through the exam itself, to prepare for it and to get through that exam. And so that's just sort of a little bit of a roadmap for what we're going to be discussing today. If you do have questions, please put them in the chat. Julie and Kim are there to answer those questions, any tech issues as well. And so, and also there's a handout. So if you click on there should be a little section that says handouts. If you click on that, you should be able to get the PDF, and it has a few of these key slides there. And the things that we're focusing on today are those items which most people usually do not score well on the exam. And so that's why we're going to go over some specific topics to help to shore up what you know about these topics. So when counseling clients with older nurslings, be mindful that the number of feedings and the time at the breast could fluctuate greatly. Babies might return to intense breastfeeding to adjust their parents' milk production as needed, which is something referred to as growth spurts. This often occurs around 2 to 3 weeks, around 6 weeks, and then again around 3 to 4 months. Coincidentally, it corresponds with a shift in the maternal hormones and with the gradual transition from the endocrine to the autocrine control of milk production. Developmental milestones may increase night waking as well as nursing. These little ones seem to be way too busy during the day exploring the world in order to stop and take time at the breast. They may miss something if they do that. Therefore, they may wake more frequently at night to receive the caloric intake they intrinsically know they need. Latch and positioning technique is considerably more flexible after the first few months. Note in the picture here that the baby is further away from the breast than when the baby was a newborn. Unless the parent is uncomfortable, there's no reason to suggest changing the position or the latch. So breast and nipple pain are two challenges that some parents face while lactating. This is one portion of a 13-page algorithm developed by UNC for breast and nipple pain. It's very valuable, and it's a good review prior to the exam for how to identify many of the causes for breast and nipple pain. And it is in your handout. So mastitis is an infectious process in the breast that produces localized tenderness, redness, or discoloration of the skin and heat when touched, together with systemic reactions of fever and malaise. Prospective studies estimate the incidence to be between 3 and 20%, depending on the definition and the length of follow-up postpartum. Technically, mastitis is an inflammation of the breast, which may or may not involve an infection. The problem can begin with engorgement, then non-infective mastitis, followed by infective mastitis, and abscess if treatment is not introduced promptly. Symptoms include a fever of 38.5 degrees centigrade or 101 degrees Fahrenheit, chills, headache, flu-like body aches and symptoms. The breast is painful and swollen. The breast area could be red or discolored, hot, tender to the touch. And you may notice either red blotches or streaks on the breast or bruising or discoloration of the breast tissue. So treatment is going to be rest, continue to feed, pump on the affected side, warm compresses, creative nursing positions, pointing the baby's nose or jaw towards that area on the breast, which may be infected, is the best way in order to relieve some of that fullness and some of that congestion. You want to support, as the lactation support provider, lactation consultant, you want to support compliance if antibiotics are prescribed, and use analgesic or an anti-inflammatory for discomforts, fever, and swelling. So now I intentionally chose this picture to see if you can see where the mastitis is. It can be challenging to see inflammation or redness on someone who has darker skin tones. It's not going to show up that way. It's not going to present in that way. So just be mindful of that if you see something like that on the exam. So for recurrent mastitis, Staphylococcus aureus is cited by Dr. Lawrence in her book, Breastfeeding: A Guide for the Medical Profession, as a common cause for breast infection. Jimenez found that Staph aureus dominated the microbiome of mastitis sufferers. However, Staph aureus is found by other researchers in the milk of asymptomatic women. In the case of recurrent mastitis, we want to take a look at the causes. And usually it's delayed or inadequate treatment of the initial disease followed by continued milk stasis. The diagnosis can be made with a culture of the milk and an infant nasopharynx or oropharynx. Treatment options and a thorough discussion of mastitis can be found in the Academy of Breastfeeding Medicine's protocol number 4. I highly recommend, if you haven't discovered the Academy of Breastfeeding Medicine's protocols, they're absolutely phenomenal. They're international, they're multidisciplinary, and they're updated about every 5 years. So for a breast abscess, a small percentage of women develop these where breast infections will develop into an abscess. Kinley reported the incidence to be anywhere from 5 to 10%, whereas more recently, Amir found that about 3% of women with mastitis may develop an abscess. One theory is that healthcare providers are more educated in the prevention of abscesses, as far as why we're seeing it less and less. Dr. Lawrence reports an increase in abscess rate when antibiotic treatment is delayed beyond 24 hours. So what it is, it's a localized collection of pus that forms from an infection that has no opening for drainage. The indications for abscess are the same as mastitis, although the symptoms may be less severe because the abscess is isolated from the rest of the breast. This picture demonstrates an obvious abscess. Occasionally, an abscess can occur in the absence of any systemic symptoms. When antibiotic treatment was delayed, as I mentioned before, the abscess rate increases. So as far as treatment is concerned, Kataria in 2013 reviewed some of these treatment options. For small abscesses, which are considered less than 3 centimeters, the recommended first line of treatment is fine needle aspiration, single or repeated, preferably under ultrasound guidance. For abscesses greater than 3 centimeters, a percutaneous suction catheter may be placed for 3 to 7 days with oral antibiotic, which is effective against penicillin-resistant staphylococci for 10 days. For larger abscesses, the healthcare provider will incise and drain the area. A drain is placed to promote drainage. The incision heals from the inside out, usually within a week or two. The parent may continue to nurse on one or both breasts, depending on the location and the associated pain with the medication. So nursing through pregnancy. It may occur, pregnancy can occur while nursing. It's important to explore the parent's feelings about continuing the breastfeeding relationship. Many women note nipple and/or breast discomfort when they become pregnant. Some report the discomfort alerted them to the new pregnancy. Depending on the age and the nursing relationship, some nurslings may be reluctant to wean. Mature milk will change back to colostrum sometime around 4 to 5 months into the pregnancy, which may change the taste and the quantity of the milk. Oxytocin is released during nursing. However, oxytocin is blocked by progesterone. There is no need to wean a nursing baby or child unless there is a true risk, which means a history of preterm labor. There's limited data which shows an impact to the mother's nutritional status by continuing to nurse through pregnancy. Therefore, it's important that the parent is mindful of their diet. Some older babies and toddlers may stop nursing during the pregnancy and then resume after the birth. Tandem nursing is the term used to describe breastfeeding of one or more children who are not born at the same time or at different ages. It occurs when a mother nurses through their pregnancy, or if a previous child weaned during pregnancy, they may be interested in resuming. It's important to explore the parent's feelings about tandem nursing. As one of the pioneers in the profession, Shelley Marmez, once said, it takes the patience of Job to tandem nurse. If there's an issue with the infant's weight in the early days, ensure that the newborn is given priority at the breast. Some mothers will dedicate one breast to the newborn and the other to the toddler, and then switch the next day. Here we can see how the older sibling has her arm around her new brother. Granted, it may be so everyone can fit on mom's lap, but it also could be a sign of affection. If a parent expresses a need to wean, it's important to explore their reasons. Some families believe that weaning may increase a child's independence or help a child sleep more at night, which may not be achieved through weaning. Gradual weaning works best for both parent and baby. It reduces the risk of severe breast pain and mastitis. In several texts on nursing a toddler, the first suggestion is don't offer the breast and don't refuse a child's request to nurse. You want to eliminate a feeding about every 2 to 4 days and preferably not back-to-back feedings. Continue as both the parent and child are accommodating this new schedule. Hand express for comfort as needed. Change the daily routine for the child so that alternatives to nursing are offered and explored. Offer other foods and drinks just before regular nursing sessions. And breastfeed when asked, but for shorter time periods. Okay, Sekeita, are there any questions? Anything I should address before I move on?
check here. I think at last check, I believe I answered the majority of the ones that were flagged. But before we move forward, let me see. Doesn't look like, nope, not any that are flagged right now.
Okay, great. Okay, good. All right, I'll keep going. Thank you. Okay, now we're going to talk about milk supply. So this is a picture of the neuroendocrine reflex arc to remind us of the physiological mechanisms of lactation. Milk synthesis is a complex interplay of the hypothalamic pituitary gonadal axis. Milk synthesis is related to the degree of breast fullness. Suckling or expression or other nipple stimulation stimulates prolactin secretion and the release of oxytocin. It's milk removal that enables milk secretion to continue. So this is a slide you may have seen in the anatomy and physiology or the relactation exam review. According to Margaret Neville and Jane Morton, failed lactogenesis can be described as preglandular, glandular, or postglandular. An example of preglandular would be hormonal causes, such as retained placenta or lack of pituitary prolactin. Glandular causes might be surgical procedures, such as reduction mammoplasty or possibly insufficient mammary tissue. Postglandular would be any cause for ineffective or infrequent milk removal. This would include those iatrogenic reasons which cause lactation failure, as those are which are impacted by the policies and procedures in a hospital or by healthcare providers, and they can have a negative impact on milk production. A parent's perception of milk supply in the early hours and days after birth could be included here. It's a common perception that a sleeping or quiet baby is a happy baby. Parents may misinterpret baby's lack of settling post-feed as a sign that baby isn't getting enough and supplement. Parents may interpret normal newborn nighttime circadian rhythms as a sign that the baby is hungry and assume a lack of milk and supplement. So other ideas for postglandular for this ineffective or infrequent milk removal. So these iatrogenic regions that I mentioned before. So the separation of mother and baby, pacifier use, and as mentioned in the previous slide, this perceived insufficiency by the staff or by the family, which leads to supplementation. Now remember, interventions which require supplementation, and if the milk supply is not simultaneously supported through hand expression or pumping, could reduce milk supply. And consider the scenario, especially during some of the case studies that may show up on the exam. Supplementation is started. The parents are told that they have to supplement their baby, and therefore the parents may feel that their breastfeeding has failed already, and they're worried about resuming it. They're afraid to resume it. Well-meaning healthcare providers may not encourage the resumption of breastfeeding if the interventions are effective. Common scenarios such as a baby diagnosed with hyperbilirubinemia in those early days after birth and supplementation with breast milk substitutes is begun, or a 2-week-old baby who wasn't gaining effectively and begins to gain with supplementation. In both of these cases, the parents may be afraid to resume exclusive breastfeeding, and healthcare providers may not have the time to create a plan to help the baby return to exclusive breastfeeding. Finally, there are some cultural beliefs that create a barrier to normal breastfeeding, such as colostrum not being enough or something which is bad for the baby. So anomalies of maternal breast tissue include the surgical interruptions in the breast, such as a biopsy, which is seen on the picture on the left, a reduction or augmentation, which I do not have a picture of that here, but you can notice the reduction. You'll notice the scarring around the breast tissue when a reduction mammoplasty has taken place. Also augmentation, it's important to note where the scars are, where actually the incisions were made, and where the implant is, if it is above the muscle or below the muscle. And also a chest tube. As a preterm baby or a thoracotomy prior to breast development. Again, any of those incisions can be seen on the breast when you're doing a breast exam. Mammary hypoplasia or insufficient glandular tissue, as seen in the picture in the middle. breast asymmetry, including intramammary distance or the space between the two breasts. All of these things could indicate the possibility of an impact on milk supply, but not a guarantee. It's really important to note that. Okay, now we're going to go on to maternal disease. So chronic disease such as hyper or hypothyroidism, lupus, Parkinson's, diabetes, hypertension can all have impact on a milk supply. Acute illness or birth-related complications, including hemorrhage after birth, especially causing large sudden drop in blood pressure and or requiring a blood transfusion. So as a point of reference, 500 milliliters of blood loss is considered normal. Hemorrhage may cause damage to the pituitary, ranging from a mild insult to major infarction. Sheehan syndrome is a severe hemorrhage and drop in blood pressure that may result in necrosis of the anterior pituitary. Hormonal issues were referred to a few slides ago, and they're worth mentioning again. Irregular menses, infertility, obesity-related issues, PCOS. Weight loss surgery, specifically gastric bypass surgery, can impact the amount of nutrient absorption. Other factors include delayed lactogenesis 2, such as greater than 72 hours. Now, each one of these points could be reviewed in depth. If you have further questions about the specifics, please review your notes or the lessons or take a look at the literature. So premature delivery, insulin-dependent diabetes mellitus or gestational diabetes. Metabolic status or health refers to an interesting study from Nomson Rivers et al. In 2012, which described 3 major risk factors for delayed lactogenesis: a higher BMI, increased maternal age, and larger infant birth weight, as known correlates with carbohydrate intolerance and systemic inflammation. And it's also important to mention fat-phobic bias and the staff which are unaware of their bias. Some of these staff members may not want to work with someone who is overweight. And I really want to thank Kristen Cavuto for bringing this important concept to our attention. So other delayed lactogenesis 2 risk factors can include hypertension, high stress of the mother or the fetus during the birth, cesarean birth, especially when urgent, prolonged stage 2 of labor, which is considered greater than an hour, augmentation of labor with intravenous fluids, forceps or vacuum delivery. The timing of the first breast stimulation is really important following delivery. The evidence shows us that milk expression needs to occur within that first hour after birth, and that it can actually improve not only the copious onset of milk supply, but also the timing, and the earlier that you begin milk expression, the better off it is at 1 hour even compared to 6 hours. Whenever we note significant edema of the extremities, that can impact milk supply, as well as endocrine disturbances. Now, there are several other complex interrelations which exist among the various factors that could impact lactogenesis. Whether the delay of lactogenesis 2 is a maternal physiologic response due to delayed or inefficient suckling, or a combination of factors, it's not clearly been identified. Early, frequent, and effective breastfeeding appears to be the most important factor in establishing normal lactation. And frankly, I would argue that skin to skin and milk expression in that first hour after birth are really the key factors to counter the possible risk factors that could impact lactogenesis 2. For those of you working in a hospital setting, you can understand how that may be impeded with any of the above diagnoses. But now we're not just going to take a look at the mother's role in milk production, we also want to take a look at the infant's role in milk production. Any issue which affects sucking or suckling frequency may affect the initiation and calibration, which are terms from Marshall Walker, of milk production. The baby may not be capable of sufficient milk removal to initiate and maintain an adequate supply. Important factors include the gestational age, premature infants, of course. Remember that those late preterm infants may not suckle well enough for adequate milk removal. The infant's oral and facial anatomy can impact milk removal. Any tongue mobility restriction can impact not only maternal nipple discomfort, but also the ability to remove the milk. Palatal issues obviously include a partial or complete cleft of the hard or soft palate, but also include a high, bubble, or channel palate. Airway issues such as laryngomalacia or tracheomalacia can also impact milk production. Long term, the issues on the previous slide can impact the initiation and calibration of the milk supply. The following can impact the maintenance of milk production. In the immediate postpartum period, that would be an infant with hypotonia or hypertonia, birth trauma pain, such as shoulder dystocia or the use of forceps or vacuum, cardiac or respiratory issues. And you'll note with this picture in the slide, the baby, the inflammation, the redness that you see on the baby's scalp is actually quite a large cephalohematoma that the baby had on their scalp after vacuum extraction. Long-term impact can be infant facial anomalies of the tongue and or the palate, and any sort of sensory integration issues. All of these issues can impact the infant's role in being able to remove the milk efficiently and effectively. So some solutions. Always like to end with some solutions and suggestions. So prenatal education can reduce the use of supplementation in the early days by the parents who believe the baby isn't getting enough. During the hospital stay, always recommend frequent skin to skin. I don't think it's something that can be overdone. Frequent colostrum and milk removal. Hand expression seems to work best. A quick note, for parents who are pumping for their premature infant or having trouble extracting an appropriate amount, utilization of the other senses can help with the milk ejection reflex. A study noticed an improved milk output when the parent was looking at pictures of her baby and or listening to the baby's cries or coos, as well as smelling their t-shirt or blanket from the day before. It's also important to educate parents about the normal newborn circadian rhythms. Visuals of the newborn stomach and or the nominal nutrition requirements in the early days can be reassuring. Also, it's important to set realistic expectations for the frequency of feedings as well as the duration of feedings. If supplementation is required, alternative supplementation that do not disturb that direct breastfeeding relationship or can complement it effectively. And of course, follow up. Always important to follow up to make sure that the parent is feeling comfortable and to adapt the care plan as needed. Okay, Sekeita, any other questions that we should address before I move on?
Yes, Angela, please. There is a question, and it's asking, are measurements on the exam in imperial and metric? Do we need to do our own conversions?
Fortunately, no, you do not need to do your own conversion. They will be listed in both imperial and metric. So you don't need to bring a calculator.
And then, Angela, I wanted to just comment on one of the slides about endocrine disorders, just so that to clarify what those means, what disorders could mean, particularly in maternal child. The most common ones you'll see will be diabetes, that's an endocrine disorder, hypothyroid, hyperthyroid, anything impacting the thyroid. That's also, those are the most common ones. But there's also prolactinoma, which is an overproduction of prolactin. So those are some of the key when we talk about endocrine disturbances. I just wanted to elaborate a little bit. Otherwise, Angela, I think you've been doing great. That was the only question that's been flagged. Our team that's supporting us, they're excellent. So you can keep going.
Great. I love it when everybody's on their game. Okay, good. So now we're going to talk about everyone's favorite subject, which is research. So we want to take a look at different variables in experimental studies. So I'm just going to familiarize you with a few of these terms. The dependent variable is what the independent variable acted upon. In a study on breast pumps, here's an example, in a study on breast pumps, the volume of breast milk obtained when using several types of pumps was compared. The volume of milk is the dependent variable, and the type of pump is the independent variable. Consider what we know about the effectiveness of pumping, though. It can be impacted by a number of factors. Therefore, a compounding variable in this example might be the privacy of the place where the parent is pumping. That could lower the amount that they're able to extract, or time of day. We know most parents will extract more milk earlier in the day as opposed to later in the day. And so time of day could be a confounding factor. And these other terms that you may see, so is standard deviation. The standard deviation is a measure of how spread out the numbers are. 68% will fall in the first standard deviation, 95% will fall in the first and second standard deviation, 99.7 will fall into the first, second, and third standard deviation. And you're only going to see a few on either side of that bell curve, so there's only going to be a few in that fourth standard deviation. Statistical significance is the level of certainty in the results of a study. If we want to be 99% confident of our results, we set the significance at 0.01. If we want to be 95% confident of our results, we set the significance at 0.05, which is most medical research. Bias. There are different types of bias, and it can influence research. For example, a piece of research that looks at the effectiveness of breast pumps, specifically the frequency of the number of cycles per minute. You note the university who supported the research is funded by a specific breast pump company. The researcher, whose university receives funding from that pump company, could be biased in their study design and/or the interpretation of results. So it's important to know the bias and to see who's actually funding the research. Informed consent. Subjects need to be informed about their rights, equipment, and medications which are used, procedures, confidentiality, and how to withdraw from a study at any time, as well as any rewards for participation. Okay, so that's it with research. And I know usually people have questions about that. Anything that I need to address before we move on to questions?
Yeah, let's address this one question, Angela. It says, does IBLCE ask questions such as calculating infant weight loss?
I believe they do not, and I will allow for either Julie or Kim to check me on that one, but I am relatively confident that they do not. I think it's helpful though if you can see, and they should provide that calculation for you, but you should need to know what an average weight gain is per day. And therefore, if you presented with a scenario in those first few weeks, it's important to note whether or not it's something to be concerned about or not. And so do be mindful of those things, although you're not going to have to calculate some of that information on the fly. Again, calculators are not allowed. So you won't have to like take a pencil and paper in order to calculate those numbers. But do know what an average, so for example, if you're only used to imperial weights and all of a sudden you see a weight of a metric weight of a baby, it's helpful to know what an average birth weight is for a term baby. It's helpful to know what an average weight is for a preterm baby. And then that way you can see quickly and know quickly exactly what that looks like. So that you can see, for example, if you see a baby who weighs 4.8 kilos, that's a ginormous baby. And therefore, that's probably either an older baby or it's a baby who was way post-dates and or the parent could have had issues with their blood sugar during pregnancy. So that's a ginormous baby. I don't even think that's possible. Is it, Sekeita? Anyway, okay. So now
anything is possible, but with probable, but anything is possible. But anyway.
True, and we don't want to focus on those things outside of the bell curve. Remember, the IBLCE exam is to take a look at the minimally competent IBCLC. So those ifs and buts, like that small percentage pieces, are not going to be on the exam. We're looking for the average. We're looking for what usually will happen. So be mindful of that. Okay, now comes the fun part. So now we're going to get to questions. And so what we're going to do is I'm going to pop up a question, and then we're going to have a poll that shows up. And so Steve is going to then put up the results, and then hopefully I'll be able to navigate and see when everybody has answered the question, and I'll be able to provide us some real life feedback. And so really excited about going to the questions here. Okay, so here is the first question. So we've got physical breast presentation, which may contribute to low milk supply, is a significant inframammary fold, breast cup size less than B, breast cup size less than B, significant intramammary distance, and hypoplasia of the superior breast tissue. Okay, Steve, go ahead. So Steve popped up the poll. Got people answering. We're going to give people good 30 seconds, maybe 45 seconds to answer the question. So there is a sophisticated distractor here, just FYI, including that medical term, a couple of medical terms in there. Got about half of you, a little bit more than half of you who voted. Great, 73%, 75. Okay, great. So the results are that 66% of you got the correct answer, which is significant intramammary distance. So that's the space between the two breasts. So hypoplasia of the superior breast tissue is the breast tissue that's up on the chest, right? So if I should have brought my breast with me, if this is the breast, it's the breast tissue which is here. And then we have a significant inframammary fold. That's if you take a look at the side of the person, that's where the breast is actually attached onto the chest itself. So that is not something that's not a physical presentation which we know could contribute to low milk supply, although I have seen it in a rare number of cases. And none of you guessed breast cup size less than a B, so right on. Okay, good. Next question. A postglandular reason for insufficient milk production is early introduction of hand expression, pacifier use, retained placenta, previous breast biopsy with a periareolar incision. Okay, Steve, time for the next one. A postglandular reason for insufficient milk production. Doing well. About 50% of you have voted. When we get to 75%, then I will close it down. Okay, great. And so the answer is, closing it down, the answer is pacifier use. So more than half of you said pacifier use. And so you are, 56% of you are correct, it is pacifier use. Retained placenta is not going to be a postglandular reason. And previous breast surgery is going to be a glandular reason. Okay, good. All right, going to the next one. And just want to make sure that everybody is able to see. So if you cannot see the question, please do speak up. Okay, next one. While reviewing your postpartum patients chart, you see they received Pitocin, synthetic oxytocin, and Methergin. I didn't practice this before. Methylorgonavine maleate. I apologize if I mispronounced it. After a vaginal delivery, you know this patient will most likely A, experience a normal blood loss, B, experience excessive blood loss, C, gave birth to multiples, D, will not be able to breastfeed. So you notice those medications in the postpartum patient's chart. So what do they tell you? Okay, go ahead, Steve. Oh, I don't think we're fooling you on this one. So far, so good. About 40% of you have voted. This is great. Okay, good. 64% of you. Come on, go ahead and ask. Okay, great. I think most of you have this one, which is that they experience an excessive blood loss. So over 80% of you answered experience an excessive blood loss, which is correct. Remember, normal blood loss is about 500 milliliters. And Pitocin and Methergin, and I apologize for using those American terms, those are medications which will stop bleeding. In other words, Pitocin will allow for the synthetic oxytocin will allow for the uterus to contract. So that usually tells you that yes, indeed, there was blood loss. And as far as whether or not it will impact their ability to breastfeed, we do not know that because what's not in the stem is the amount of blood loss that occurred. Okay, good. Next question. Lilo Lactation Consultant did a study in their hospital where she surveyed the parents' duration of breastfeeding. She found the range was 1 week to 18 months with a mean of 8 months. What type of research is this? Is it quantitative, qualitative, historical, or epidemiological? This is great. About 30% of you have voted so far. Keep going. You know this. Quantitative, qualitative, historical, or epidemiological? Okay, great. I think we're going to close it because most of you, so 74% of you said the correct answer, which is quantitative. So it's based on data. It's not experimental, and there's no attempt to determine causality. So it's historical. That's a good sophisticated distractor in that they're asking something which happened in the past. However, take a look at quantitative and qualitative, and you'll see that it actually meets those metrics. So qualitative research explores reality based on perception, considers multiple perspectives, no attempt at causality. Quantitative research is based on data collection and analysis, experimental, and it attempts to determine causality. Okay, next question. Lilo, again, is busy at their facility, and they did another study in which she surveyed parents about their satisfaction with breastfeeding and what type of problems they encountered. What type of research is this? Okay, same options: quantitative, qualitative, historical, or epidemiological. So you'll note here that we had a quantitative question before, and now we've got another question, and it uses the exact same terms. Now, IBLCE does try to not give you the answer to one question based on another question. They try. And so for any of the questions that you happen to flag when you're actually taking the exam, don't flag like a bunch of them thinking that maybe another question is going to give you a clue as to the answer to that question, because IBLCE usually is pretty smart about such things, so they may not do that. And we can see in this one that didn't fool you. So 96% of you got this one right. So it is qualitative. And again, just taking a look at what the difference is between qualitative and quantitative. Remember that when you're actually sitting the exam. And yes, this slide is actually included in your handout. Okay, great. Going to the next question. Iron levels are low in breast milk. What instructions should parent be given? A, supplement with iron drops until the baby begins solid foods fortified with iron. B, breastfeed, no supplementation needed. C, breastfeed and supplement at 6 months with iron fortified foods. D, increase the amount of iron in your diet and to increase the amount of iron in your breast milk. Okay, go. So which one is the right answer when iron levels are low in breast milk? And you want to remember, I'll give you a clue, any World Health Organization guidelines here. So anytime you're in doubt and uncertain, definitely go with the World Health Organization, or if the Academy of Breastfeeding Medicine has guidance, those are the places where you want to go. Remember that this is an international exam. It's not just based on the country in which you're sitting the exam. Okay, good. Another few seconds. Ah, there we go. Great. So 49% of you got this correct, which is C. Breastfeed and supplement at 6 months with iron fortified foods. So additional iron intake by the mother will not increase the iron levels in breast milk, even if the mother is anemic. And iron supplements taken by the mom may produce constipation in the baby. Anemia in the nursing mother has been associated with poor milk supply. However, we do want to just go ahead and breastfeed and supplement at 6 months with the iron fortified foods. You do not need to provide the baby with supplement drops before 6 months, unless they've done blood work on the infant and there's actually an issue. So, great. Okay, next question. Now this one is on vitamin D levels. So we had iron and now we have vitamin D. So vitamin D levels are low in breast milk. That's a fact. What should be done? Supplement the baby with vitamin D until solids are started. Breastfeed, no supplementation needed. Breastfeed and spend a half an hour outdoors daily. Babies should be supplemented with 400 IUs of vitamin D daily. Okay, go. So we saw iron, and now we're seeing vitamin D. Those are questions that could be on the exam. There may be a couple of sophisticated distractors in this question. And that's the reason why if you look in the STEM, it states a fact. Vitamin D levels are low in breast milk. And the reason vitamin D levels are low in breast milk is because we're intended to get our vitamin D in a different way. Leave it open for another few seconds. Okay, great. And so the answer is D. Babies should be supplemented with 400 IUs of vitamin D daily. And so the answer with breastfeed and spend a half an hour outdoors daily, while that may be a suggestion in certain parts of the world, it's not a suggestion or recommendation worldwide. Because if you are in an area where, and I'm doing this because if you're at the northernmost hemisphere, the southernmost hemisphere, then that may not be something which is necessarily recommended. Plus, we also want to make sure that babies don't get any sort of sunburn. And the vitamin D, so on vitamin D, the World Health Organization states, and I quote, "There appears to be consistency across the world that newborn infants are at an elevated risk of vitamin D deficiency and that a vitamin D supplement to exclusively breastfeed is highly recommended in the primary prevention of vitamin D deficiency and rickets." So again, World Health Organization is always the place to go. Okay, great. Going on to the next question. Now this next question is a picture question. So how old is this baby? And so the question is, and I'm going to give you a few hints on this one. So you'll notice that the baby has a social smile. The baby is able to lift their head at about 45 degrees. They're holding their head up for a few seconds, and they're visually searching to locate a familiar face or a sound. So is this baby A, 2 weeks old, B, 4 months old, C, 2 months old, or D, 8 months old? Okay, go ahead. And let's see what you think. So you want to take a look at some of these cues and then think about babies and when they will start to develop some of those things. Also notice how high the baby's head is. And take a look at the baby. Is that baby large? Is the baby small? Also take a look at the baby's fists. What does that tell you? Does that say anything to you? I don't know if you can change your answer in this one as I'm sitting here giving you all kinds of hints, but 75% of you have voted, so keep going. Okay, great. So the answer is actually 2 months old. So this is just a little bit of the, a little bit of a challenging question from 2 months to 4 months. So we would expect for a baby to be able to push up and to look and to smile. That social smile, though, is something which can start earlier, somewhere around 6 to 8 weeks. And so that's something which can start earlier. You're noticing that the baby's able to lift their head, but notice how their fists are tight. And so that tells me that this baby may not necessarily be a baby who can open their palms and open their fist and be able to like look around at their world easily. And so this is just a brief picture of a baby, you know, parents who are really excited that their baby could lift up their head. And so you'll notice that the eye of the image is low. And so this isn't a parent from above, this is a parent down low taking a picture of that baby. So the answer is something which is 2 months. A majority of you did not get the answer correct. You said 4 months, and I can see exactly why you did. And so let's say that this sort of question is on the exam. And let's say that most of you did not choose the correct answer. Do you know what IBLCE does? And one of the reasons why it takes so long to get your exam results, IBLCE will actually take a look at how this question performs statistically. And they have their psychometrician, their psychometric company, actually take a look at how it performed. And if this question was not a good question, they're going to throw it out and then they're going to rescore everything, which is why it's important to answer every question on the exam. Okay, going to the next one. So the next question is, which of the following viruses is most likely to be transmitted to the infant through breast milk from an infected parent? Hepatitis C, herpes simplex virus, the varicella zoster virus, or cytomegalovirus? Okay, go. So do expect to have questions like this on the exam. I know we talked about varicella before. Also notice that they're not saying any sort of, in other words, this is not a case study where they're actually saying what the situation is, how old the baby is, how old the parent is, and not that that matters, sorry, and whether or not there is any sort of treatment being provided to either the parent or the baby. So none of those things are in this question. It's just a straight recall question. So which one of these viruses is most likely to be transmitted? And great. Most of you got this correct, and the answer is cytomegalovirus. So CMV transmission from parent to an infant occurs in 60 to 70% of breastfeeding dyads where the breastfeeding parent is infected with CMV. However, healthy infants who acquire the infection in this manner are almost always asymptomatic, and breastfeeding should be encouraged. Premature infants and immunosuppressed infants are at higher risk of complication from CMV infection, and there is debate about whether these infants should receive CMV positive breast milk. Herpes simplex virus and hepatitis C are unlikely to be transmitted via breast milk. Varicella zoster virus causes chickenpox in zoster. Infected parents should be encouraged to breastfeed, as we mentioned before, and the infant should be protected from direct contact with skin lesions. And so, even though I mentioned that there's debate about whether or not these infants should receive the CMV positive breast milk, the question is which of the following viruses is most likely to be transmitted to the infant through breast milk from an infected parent? And so 60 to 70% of breastfeeding dyads, it can occur. So the CMV transmission can occur. So that's the reason why the answer is CMV. Okay, next question. Tyler is a vegan. What would you suggest to ensure adequate nutrition for the parent and the baby? So would you recommend protein from beans and rice, minerals such as magnesium and selenium from grains, folate from dark green leafy vegetables, or B12 from fortified foods or supplements? Okay, so answer the question. Which one would you need to suggest to the parent to ensure adequate nutrition for both the parent and the baby for a vegan parent? Well, I don't think we're fooling you with this one. So far, 90% of you have this right. So I think we can close this one, Steve, because most people have gotten it. And that is that 86% got it correct, which is B12 from fortified foods or supplements. So vegan diets include no animal products, which are the only dietary source of B12. To avoid a B12 deficiency, vegan nursing parents and those who consume very little animal protein need to take steps to make sure they receive vitamin B12, either from foods enriched with B12 or by taking a regular B12 supplement. So great, Most of you got that one right. Okay, good. The primary reason for supplying breast milk for premature infants is to A, improve bonding between breastfeeding, chest feeding parent and baby. B, to assure continued breastfeeding, chest feeding after discharge. C, prevent necrotizing enterocolitis. D, improve neurologic outcomes. Okay, which one is the primary reason for supplying breast milk for premature infants? I wish I could be with all of you during the exam so I could like say things and like emphasize words. That's not going to happen. Sorry. Okay, great. Collecting responses. 60% of you have voted. 70%. This is great. I don't think we're fooling people here on this question, which is fine. Okay, great. So the correct answer is C, preventing necrotizing enterocolitis. And so that is the primary reason for supplying breast milk. The other reasons are important and they are accurate, but the primary reason for supplying breast milk to baby is to prevent NEC. Okay. Risks of skin-to-skin care in newborn infants include respiratory instability, sudden unexpected postnatal collapse, hypothermia, and sudden unexpected infant death. SUID. Okay. What is the risk of skin-to-skin care? Here, I'm a huge fan of skin-to-skin care, and yet there is a risk. I think this one is stumping a few people. About 60% of you have voted so far. You're thinking about it. Give you another couple of minutes here, couple of seconds, sorry. I know you want to go on to the next one. Okay, as I'm looking this up, thank you so much, Steve. As I'm looking this up, the correct answer is B, sudden unexpected postnatal collapse. And just want to read to you a quick piece from Dr. Ruth Lawrence. And it's important to note that sudden unexpected postnatal collapse is something which is becoming a thing. It is not because of the baby-friendly initiative, but it is something which is being noted and is being blamed on many things. However, there is a very important piece to skin directly after birth, which is supervision. So it's important for both the parent and the infant to be supervised after the birth of the baby. SUPC refers to a life-threatening incident during hospitalization following birth that may or may not result in death. Infants appear to be at the highest risk for SUPC during the first 2 hours of life while in a prone position and unsupervised. There is a quality improvement bundle designed to prevent SUPC while encouraging appropriate breastfeeding care, including skin-to-skin. And so it's really important. Some of the things that are important is that you want to make sure that the infant's nose and mouth are visible and that the parent is not laying flat on their back, but that they're in a semi-reclined position and that there are no clothes between the parent and the baby. You want to make sure that the parent's airway or that the baby's airway is something which is stable. And so sudden unexpected postnatal collapse, if you haven't heard about it, do take a look and see if you can find a little more information about it. But 70% of you did get this correct. Okay, taking a look at this picture. This technique is useful for all infants except, there's that negative stem, premature infants, Down syndrome infants, neurological impairment, infants with type 3 ankyloglossia. Okay, great. Okay, good. So what is this technique? So you have to recognize the technique. And then why is it useful? It's useful for 3 of these, but not with 1. So what's the answer? Just another couple of seconds. Okay, great. Now you see here that infants with type 3 ankyloglossia is the distractor. And so the answer is actually the answer. It's not a distractor, it's the answer. And so yes, the answer is D. So this is the Danner hand. As you can see, as I'm modeling it here, this is the Danner position. And so what it does is it actually supports the baby's chin, and or the fingers can support the baby's cheek in order to help the baby to effectively transfer milk while at the breast. And you'll also notice that this baby is in a side straddle position facing the parent. And so this is helpful for premature infants. It's also helpful for babies with Down syndrome and any sort of neurologic impairment. So this is the Danner hand position. It's also, you may also see it in your references as dancer hand position. So Danner, dancer, it's the same one where we're basically giving the baby's chin and oral musculature a little bit of support with the parent's hand. Okay, great. 60% of you got that one correct. It's not indicated for type 3 ankyloglossia. And I would also expect not to have every single question with regarding any sort of tethered oral tissues, just FYI. Okay, the World Health Organization guidelines, this is the last one, for preparing powdered infant formula recommend A, boil the bottles and teats for 20 minutes, a rolling boil. B, boil the water used for mixing for 20 minutes, a rolling boil. C, mix the measured amount of powdered formula and hot water, so 70 degrees centigrade to 150 or 158 degrees Fahrenheit. And D, store prepared bottles in refrigeration for up to 72 hours. So which answer is correct? What does the World Health Organization recommend? So do you want to boil the bottles and teats for 20 minutes, boil the water used for mixing for 20 minutes, mix the measured amount of powdered formula and the hot water, and store prepared bottles in refrigeration for up to 72 hours? 60% of you have voted so far. It's just a little tricky, especially if you're not familiar with the World Health Organization guidelines, or if you're only following the can, the tin of breast milk substitute. Okay, great. 80% of you have voted, and the correct answer is C. Mix the measured amount of powdered infant formula and hot water. And it has to be at this temperature. And so the sophisticated distractors were the first one and the second one, because it said that it needed to boil for 20 minutes. That's too long. Actually, I believe the bottles and teats, you boil them for 5 minutes. I could, check me on that one. And then boil the water used for mixing for 20 minutes. It doesn't need to be boiled for that long. It only needs to get brought up to a boil, and then you can turn it off. The most important thing is to mix the appropriate amount of powdered formula with the hot water. And you want to do it while the water is still hot in order to kill any sort of Enterobacteria sacchi or the Chronobacteria, which they have found in the powder of infant formula of breast milk substitutes. Okay, great. So 44% of you got that one right. So that may be something that that 60% of you want to take a look at, or 57% of you want to take a look at. Okay, that's great. So that's the last of the question. And so now I'm going to see if there are any other questions that we should address before we go into the exam day survival guide with Sekeita. Anything, Sekeita?
Yes, Angela, there are a few questions. I'll start off by answering one. And the first question is, some questions have been to specify which type of research style is being used. How can you determine this information? The way I'll answer this question will hopefully give you an easy way to think about qualitative versus quantitative. Whenever there's research regarding satisfaction of something, gauging someone's feeling, human emotion, story, anything of that nature would be qualitative, right? Anything that has to do with a number, meaning we're going to see how many millimeters of mercury impacts this thing, right? That is quantitative. So just being real clear on what types of research. You may want to look up examples of qualitative research, examples of quantitative research to make it make sense, because for some that it sometimes is a hard concept to get. And I'm saying that from a standpoint of, I remember there was a question about parent satisfaction, and there was a Likert scale used. A Likert scale means a 1 through 5 scale. And someone said, well, no, that is a quantitative study. And I'm like, no, it was measuring satisfaction. So yes, it was a measurement, but it was measuring satisfaction, right? And so really keeping those principles in mind. I hope that clears that up. But if it doesn't, please feel free to like Google like types of research, and it'll help you understand clearly what that means. Angela, there was another question. And I know the answer, but I want you to answer this. I want it to be on a recording. So, how to calculate relative infant dose, RID? That's a question.
So you're asking me to calculate relative infant dose?
No, I'm saying like someone wants
do we
to
have
know
to?
that. And
No.
I would say no, we wouldn't have to.
No.
Exactly. Okay.
Thank
That's
goodness.
what
I'm like, Sekeita, what are you doing to me?
Right.
No. You do not have to calculate relative infant dose. It's just something which is helpful to have, especially if you're going to look up a few different medications. This is something which is definitely helpful to have, is to sort of know what the relative infant dose is for a couple of different types of drugs or drug classes, which is helpful. Also, someone is asking if we can put up a slide. And so indeed, can you all see my slides? Hopefully it's the right one. So maternal disease, which could impact milk supply. So popping it up here just for another couple seconds. Any other questions?
Yes, there was a question. I think this is a clarifying question. So the water doesn't need to be boiled, it just needs to be hot. And I'll just say that, Angela, you said this, that it has to be brought to a rolling boil. So
right when it gets to, so that's 70
yes.
degrees centigrade and that 158 Fahrenheit, you get water up, you boil it, it gets to a boil, and then turn it off. And so a lot of parents who are using breast milk substitutes and powdered infant formula will get a kettle, an electric kettle. Think of a kettle. And so as soon as it hits to that boiling point, it shuts off. And so that's exactly the sort of temperature that you want to utilize, and that's where you need to go with it. So yes, someone is saying they were confused because boiling is 212 degrees Fahrenheit, correct? Yes, that is correct. And so that's just it. You notice that the Fahrenheit for the breast milk substitute boiling is 158 degrees Fahrenheit. So that's why you get it right to that point, and then that's it. Someone else is commenting that it's helpful for her to remember the term qualitative and quantitative. So if that's helpful to anyone, thank you so much for putting that in the chat.
Yeah, I like that.
Yeah, someone else is asking, how detailed will the anatomy portion be? Nerves, muscles, bones, etc. They could be included, right, Sekeita? So
yeah, I would say no, the fourth intercostal space, I would say no that. And if you don't know, this is a review session. So this is Angela and I are here to kind of guide you along the way and to help you kind of get on that right track. I would say anything related to the nerve area of the mammary tissue, mammary glands, anything in that area would be fair game.
Agreed. One or two other comments here. Someone says, non-lactating woman complains of nipple discharge. What lactation consultant will do first? Or whether we refer to primary care? Sekeita?
This says non-lactating. I got to read this again. Complaining of nipple
Non-lactating
discharge.
woman
Okay.
complaining of nipple discharge.
Okay. So Sekeita would say back, like, what type of discharge? What color is it? You know, yeah, if you're not lactating and you're not a lactation and that's not in your wheelhouse, I would say absolutely refer to a primary health care person. Yes, so that would be the answer.
And my cheeky answer to that would be not it. Meaning,
Right. So I'm not.
Sekeita is also a nurse practitioner.
Yeah.
I'm not. Therefore, I'm going to say not it. So indeed, you want to refer them to their primary care provider.
You know what's funny, Angela? As I was starting to answer that question, I was almost starting to answer in that other hat, right? And I was like, oh, wait. Yeah. So thank you. That was a great catch. Thank you.
I would be very, and I would ask all those questions as well, because I'd be super
Yes.
curious. And I have had a few parents like that. So yes, it is something which is always interesting. I've learned a lot. Let's see, is there anything else?
So yeah, differentiate the definition of early term and preterm. So preterm is any delivery before 37 weeks. Early term, oh goodness, is it 35 and 6/7 to 37 weeks? 30.
Okay.
You understand? I'm like, those old, yeah.
So take
Go
a look
ahead,
at
Angela.
Yeah, I was going to say, go to find the World Health Organization's website and
Yeah.
take a look at those. Also in our exam review sections and our exam review sessions where we've got on our website, Exam Review Enriched, it has all of that. We've got a section on preterm. We have a section on maternal disease. We have a section on an infant disease, on allergies. I mean, every single thing, research, all of them. We do modules, and they're just like the condensed version of what you need to know around each one of the topics. And so do take a look, go back and take a look at your exam review materials and see if you can find it. Okay, great. So, I do have to answer this one real quick. Different types of tongue ties and the specifics of classifications. No, you do not need to know the different classifications, type 1, 2, 3, or 4. And one of the main reasons why is because there's a discrepancy against how you describe them. Lactation consultants will classify 1, 2, 3, and 4, but dental providers will classify it 4, 3, 2, 1.
Yeah.
And so that's the reason why you don't need to know that. I would be willing to say with some certainty that if there's more than a handful of questions regarding tethered oral tissues, be surprised. And so even though tongue ties and tethered oral tissues is a hot topic amongst lactation professionals, if there's not a lot of research on it, it's not going to be on the exam. And so, and I don't mean research that was published this year, I mean research that is in the literature and can be in the textbooks. I'm pointing to my textbooks. Then, because remember, this is an international exam. And so it needs to be something which is common practice in all parts of the world and across all populations. So,
Angela, I do want to answer one more question, and this wasn't flagged, but I think it's important because, I think it speaks to sometimes for some people, it helps with the validity of us being here. And it says, have you lactated before? I think that's what that's supposed to say. And I'm going to say yes, 3 times I have. I don't know if Angela wants to share her experience, but I will say if that's a question that won't be on the exam as far as whether you lactate, but I just wanted to answer that. Yeah.
right, yeah. So yes, indeed, I too have lactated. So
Yes.
I've exercised that reproductive right. So,
yes.
All right, Sekeita. So please tell us, how can we survive this exam day?
So first off, I'm gonna say, just stop. Everybody stop and just put your hands down. Just kind of, because those questions, Angela, I was sitting on the edge of my seat, like, ooh, as I was seeing some of the responses and how folks were answering. So I'm going to say if some of you may have done really extremely well, that's good. I would encourage you to continue to study because, again, this is guide. This is not an all-encompassing comprehension of everything that you're going to get on the exam. That this is not what that is. It is just planting seeds to help you prepare and to help you be successful in your preparation. So put your hands down, take just a deep cleansing breath, because I am about to talk about survival of other things, and I want you to really be clear and listen to some of the things I'm saying, because the next portion can make or break your experience on the exam. So take a deep breath and just blow it out. Let your shoulders drop, all of it, just relax. Okay, so now that we've done that, again, I'm going to lead you into some of the common things that are necessary for you to know going into the exam that can help you prepare and be successful for the day of, so it's not so stressful. Next slide, please. Okay, here you go. So first of all, I want you to give yourself a hand clap, like seriously. Like, preparing for this exam requires passion, it requires dedication, and it requires endurance. When I say endurance, meaning those days where you like, I feel like I just can't do this, I want to give up, but you keep going in spite of, and you keep going because of your passion and because of your dedication. So I want you to know that arriving at the exam day is a reflection of all of those things: your passion, your dedication, and your endurance. So be proud that you get to this exam, all of the clinical hours, all of the things you had to do, all of the hurdles, you made it. And so that is noteworthy. And even if you still got some preparation to do, you are still enduring and you're still going. So I just want to just commend you, because we're sitting here as people who have already passed the exam, but someone who I had to sit a couple years ago again, and I was really like, ooh, wow, did I pass? And so I did not go into it thinking, that this was just going to be a breeze, it's going to be easy. I actually studied, and so really studied, right? So I want you to just keep your passion, your dedication, and that will carry you through this exam. Next slide, please. So for the last few days, you want to stay connection to that passion. You also want to celebrate your dedication. And I'm saying that in this celebratory month of August, World National Breastfeeding Month, right? You want to celebrate and be proud of your endurance, and then trust in your preparation. Next slide. So just like we started, and I told you to take a big, deep cleansing breath and just relax your shoulders, even throughout the exam and throughout today and throughout studying. Remember to take those cleansing breaths as needed. There may be times during the exam where you know something and you're just like anxious. Some folks get test anxiety. You want to remember to do that breathing. And when you breathe, pay attention to what's tense. A lot of times my shoulders are tense. So I think that's why I said relax your shoulders, because that's a little mental thing I say to myself. So whatever your mental thing, remember to do your breathing, remember to relax whatever body part that is, and keep pushing. Next slide, please. So before the exam day, you should have received a confirmation number. You got to know that confirmation number. Some of the other things to prepare for is what to expect regarding the day of the exam. Now, the exam has been fluid since the pandemic. And what I mean by that is there are some places around the world that probably are only doing live proctoring. There are some places that are doing a combination of both. You may have your choice. There are some places, depending on what's happening because of all of the things that's going on in this pandemic, that you may receive some different instructions. And so I want to be real clear to go to the IBLCE's website. If you have not, they have a whole COVID tab about the exam, frequently asked questions, all of that. But a couple key things is that your computer system has certain requirements. It has to be a computer system. It cannot be a tablet. And even the Microsoft Pro, where some folks think, you know, it's kind of like a computer, that can't be used. Any dual monitors cannot be used. And so that's something to note. That's all on that website. You need to have a stable internet connection. So one of the things the website really talks about is being in a portion of wherever you're going to be taking the exam from. If you're taking it from the live proctoring option, is to be in a place where your internet service is good. The best thing it would be to be plugged into your Ethernet, to be directly hardwired in to your connection, and that would help. And then if you are doing the live proctoring, there will be 3 security checks. And so Prometric has 3 online agents who will assist with your setup, and your examination. And they have the readiness agent, the security agent, and the remote proctor. So the readiness agent will be the one to assist you to set up and conduct your ID checks. And that process will include a photo ID at the beginning of the exam. They will also do an environmental check of your workspace. And they will also check, like they're going to want you to turn your pockets inside out. I mean, really, as I was reading the guidelines about the environmental check, they are really, really strict and specific on their security checks. So you really want to go to that website and know this information for yourself so that you don't get dismissed or disqualified during the exam. You also have to know about breaks. Now, they do address if you're nursing and that sort of thing. If you are a nursing or lactating person or lactating mom or breastfeeding mom, you really want to have incorporated and let them know that you may need these breaks. I will talk about breaks in just a minute. I will give you a little bit more detail, but these breaks have to be pre-planned. And they have to be, I am having such a brain fog today. They have to be, pre-authorized. That's the word I'm looking for, pre-authorized. All right, next slide, please. So I talked about automatic exam termination, and this is language. The first one is language I took right from the website, and I did this because Angela and I have done this session probably when the pandemic first started. We started doing these sessions and learning of this that has happened to a couple people. So I'm going to read verbatim. It says, leaving the view of the web camera without acknowledgement from the proctor, including during your scheduled break, will result in an immediate dismissal from your examination. So that means that if you're live proctoring, you will have, you have to get the okay from the proctor. That means that if you're in a testing site, you just can't, even if it's during the break, you can't just get up and go to the bathroom. Even if you have to notify the proctor. And the last time I sat was inside of a testing place in person, and I actually absolutely had to get clearance. There was a procedure that I had to do in order to even leave the testing space. So if you are live proctoring from home, no one can enter the room during the exam. Not an animal, not any one person can enter the exam. So one of the things I say is find a nice space, a quiet space, or even potentially a space where it's just going to be you in the whole house. I'm not sure, but try to do the best you can to make sure, or a lock on the door maybe, those sorts of things. You cannot turn off the light or your computer audio. You can't move your testing location. And you can't speak to or receive assistance from someone else. And as I was reading that, I thought about how this could play out. And like right now, I'm here on this GoTo webinar and thinking about my family know that I'm live, but sometimes they forget and they just walk right in and start to talk, right? So those are the types of things that I would definitely, you've worked too hard to get here. Just make sure that all of these things you have considered and you have a plan in place that you will not be this person that get automatically booted out of the exam. Next slide, please. So because IBLCE uses Prometric as their third party, as the person who conducts the test, there are certain requirements based on the website just this morning, because I wanted to make sure everything was checked out to be exactly what was in the slide. You have to install their ProProctor app, and you have to perform a system check. And this can be done prior to the exam. Your screen resolution has to be a certain specification, which is listed here. Your computer should be a Windows 8.1 or higher, your operating system. Mac is 10.13 or higher. You have to have the latest Google Chrome. So if you haven't updated in a while, you have to have the most current. Your webcam resolution should be 640 by 480. And audio. It is recommended that you have working speakers and a microphone. They are both required, and only wired devices are allowed, so no Bluetooths. And your internet speed should be 0.5 to 1 megabytes per second or greater. So if you are, I know I'm not a tech person, and so I'm always thankful when Steve joins us, because I always sometimes have tech issues. And so with that being said, if you don't know what to do in these instances, or if you don't know whether or not your screen resolution, you don't know your operating system, you don't know any of these things right now regarding your computer system, it would be a good idea to figure those things out. And also, it's a good idea to know what to do if you have technical difficulties during the exam. So these are things that are going to be right now. Angela and I, we talked about a lot of the content related things, right? You can know all of this content, everything there is to know, but if you have some technical issues during the exam, that kills your time. It has the potential to even set up a little bit more anxiety for you. So it's important to know those things now, as opposed to finding them out during testing. Next slide, please. So preparing to sit at a testing site. So all of the computer stuff I was just talking about, all of that is if you are doing the live proctoring at home or at a place that's not at a testing site. These instructions are specifically for testing sites. And so you want to read about their social distancing measures. Masks are required. They are not optional. They are required. You may wear gloves. There are some guidelines for entering the test center, so you need to know those. You want to arrive early. When you arrive early, you arrive knowing all of the guidelines. And some guidelines they may go over, but for the most part, there's like when you hear people say the devil's in the details, they truly are. And that's the reason why I went over the previous slide before, because when you think about operating systems and screen resolutions, that's those details that sometimes we seem to miss. And the fact that folks are like, I can't test on an iPad. No, I'm sorry, you can't. So review the guidelines. There is more information. I've referenced this before about their COVID page, it's particularly because, again, in this pandemic, there's been so many moving targets, so many different things that's been happening. Also, it's important to know that China has a specific policy. That global update was done on August 12th. So if you're in China, you may want to look at that. You may want to take a look at those specific policies as it relates to China. Next slide, please. All right. So before exam day, I talked about planning to be alone, no pets or people, meaning no cats either. Cats are so quiet, like dogs, you know, they do all of that stuff, right? No cats can't, no pets. Area where there's the strongest and good lighting so that the proctor can see you, and the internet is the strongest, so you need both if you're live proctoring. The other thing is, if you have other people that will be in the house, suggest that they stay off of the internet. No streaming, no social media, no nothing, everyone off. And again, as I mentioned before, consider hardwiring into your Ethernet cable. And ensure that you will have quiet time. That's the other big piece to it. The other big piece is nothing like working somewhere near folks and everyone is being loud. This is a big exam you've worked so hard for. So ensure that you have quiet time so that your mind can really process and think through the questions as you go through the exam. Next slide, please. So I like to say the day before the exam, like the day before the exam, whatever playlist you use, and if you don't have a playlist, like build one. Some people like to build playlists to relax themselves, calm themselves. Other people like playlists to like get really like excited and, you know. So build a playlist that's going to build your confidence, that will put a smile on your face. It could be favorite songs, it could be inspirational songs, it could be energizing songs, all of those things. Also podcasts, sometimes podcasts that make you laugh. There's one podcast that I could put on and just keep listening all day and just keep laughing. And so, you know, podcasts, laughter does something. It just kind of releases the tensions from our body and really help us to prepare and focus. Meditation is huge. Meditation has been proven to really assist. There is a meditation app for everything. And I know that because Angela's taught me that there is a meditation app for everything. So there may be a meditation app for decreasing anxiety for testing, things of that sort of thing. The other thing is, and I like to do this sometimes just sporadically, I know I do this for my kids sometimes, but you can write a "you can do it" note and place it on your bathroom mirror, your refrigerator. For instance, prepare your notes right now, anything that you feel that you may need, and then, you know, sporadically just stick them over your house, and so you just come across them. You know, those are things that you can do to really help center yourself and ground yourself in the day to build your confidence before the exam. Next slide. Whew. So it's important to take your exam temperature. And so what that means is do a mind check, do a memory check. What has worked for you in the past? Think about it. And then think about, ooh, that didn't work for me. And try to, you know, mold the things into your day, into that exam, the things that have worked. So as you prepare, like, you know, everyone, sometimes you're in a study group and everyone has their own set of how they study. It's important, study groups are good. For me, I'm a study alone person. So study groups are noisy for me and they don't work for me. So as it was time to prepare during the last portion, it was a lot of myself. It was a lot of, for me, writing things in my own handwriting, as opposed to just reading and highlighting them. Those are things that work for me. as I prepare for any major exam. And so I want you to think about those things. And it may be a lot other, but that's what I said. When I say your exam temperature, take your exam temperature, that's what I'm meaning. Kind of think about when you've been extremely successful on an exam, what did you do that led to that success? Next slide, please. The night before the exam, studying should be done. Just be done. So you don't have to do that last one thing, that last just cramming. If you've prepared, and I'm saying that if you've prepared, if you've done the strategies, the test taking strategies, and now we're talking about preparation. If you've done the things that are necessary, find your inner calm. Find that inner calm and get in that space. And again, I've talked about some of the ways in which and some of the strategies in which you can do that. Next slide, please. So it's exam day. Today is the day. You want to eat something that your body is used to. Not a big, gigantic breakfast of something that's so foreign, it's exotic. You want to treat yourself afterward, not before the exam. Eat something that your body is really comfortable with. Also comfortable clothing for your temperature in the home, you know, or even in a testing center, there's really not a need to dress to impress. It's a test. So really comfortable clothes, trust your preparation, and again, do your best. Perfection is not the aim. Your best is the goal. And just trust that you are ready. Next slide, please. So the test format should be 175 total questions. There's 2 parts, multiple choice, and then images. There's a 4-hour duration, and there's 30 minutes extra if the exam is not in your primary language. Each question has only one correct answer, and there is no penalty for a wrong answer. So it's really to your advantage to answer all of the questions. Answer them and flag them. You are able to flag them. If you feel like you want to go back to it, flag it, and you'll be able to go back to it. Next slide, please. Exam strategies. You really first keep calm. Like I said, breathe. You want to read slowly. What is the first thing, and you want to think about what is the first thing you would do? What is the very first thing? Before I go any further, though, I do want to make this note, because this is a note to myself. Keep in mind, this is an international exam. So for those of us that are living in the United States, this is not a US specific exam. So I want you to keep in mind, for instance, hand expression over pumping. Also, review HIV protocols if necessary, because in the United States, the protocol for breastfeeding with HIV in this country is contraindicated. In some countries, it may not be. So that's what I mean by this is an international exam. No, you probably won't be tested on the specifics of which country does what, but just keep in mind that general knowledge that international exam means that it should be questions that are geared toward the novice learner, the person who's just learning. However, you have to keep in mind that it's not US centric, okay? So what is the first thing that you think? You want to eliminate the, can you go back to that slide? You want to eliminate the answers, the wrong answers first. You want to watch out for negative STEM questions, questions such as what is not, or what is least likely, or everything except. Notice Angela did have a question on that exam. Also notice, I think it was an except question when we were doing, not the exam, when we were doing the questions. The other thing is there was a question about the premature, the question about the premature infant, about what's the most primary, the primary. So those are things you want to read slowly. And then if you go blank, just guess, breathe, and go on. Next slide. I know I'm running behind, Angela, I'm trying. Okay, so work at a comfortable but thoughtful space. Mark any questions you'd like to review. When I say mark, there should be a place where you can flag, make your best choice and move forward, and then review if you have time. But if not, make sure you answer all the questions. And again, if you go blank, breathe, guess, and move on. And yes, I am saying guess, G-U-E-S-S, guess, and then move forward. Next slide. Okay, once you've taken all your breaths, you've answered all your questions, you've gone back to the flagged ones, if you have had time and you are confident, submit it. You're done. Now, some folks will be like, oh, I finished and I still have an hour and 2 seconds. And they might go and just, overthink, go back to the question. Trust your first instinct. You can submit your exam. Trust that you did. You answered your questions. Again, if you went back and looked at your flagged ones, trust that you got the answers. So some people, when they hit submit, some people are very cautious. They're like, oh, I'm done. But ooh, so and some people are like this little guy on the right of the screen, like, my work here is done. And some people are like, okay, that done, moving on to the next. There's lots of dones, right? Some people are excited. Some people go out and they scream. I think that this person is blowing up the house and saying, yes, it's done, even though that's like a mischievous thing to do. I'm not suggesting that. Some people have mentioned things like, I really want to burn these books. No, you need your books because when you pass, you will need them for practice. And so I just want to leave you with, it always seems impossible until it's done, and that if you've prepared, if you've taken into consideration a lot of the things that Angela said, you are on your way to success. Next slide. All right, when you're waiting for your results, just try not to obsess. I'm just going to say that. Remind yourself you did your best. You do want to stay connected to your professional community to keep learning, but what you don't want to do is stay in a group where everyone keeps obsessing about checking the website. It does take a while for the results to be released. A lot of times it's right around that second or third week in December, and so kind of give yourself a heads up. But even still, don't obsess. Don't start going to the website every 3 minutes. Or even every 2 hours. That's still obsessive. So, just be easy with it. You don't want to stress yourself out. Next slide, please. Remember your why. At the end of the day, after the test results come in, all of these pictures are beautiful pictures and reminders of why we do what we do. And really, it is protection. It is protection of human life. It is health prevention. And so with that being said, I wish you all the best success, all of it. And, Angela and I are both here. If you have questions, you can always email us. Angela, any questions?
Yes, we do have a couple of comments that I just wanted to read out loud. Okay. Someone asked a really good question about the difference between parenchyma and stroma. I'm not going to put you on the spot because Julie, the amazing Julie, looked it up and put the answer in the chat, which is great. Okay. And so from Dr. Lawrence's book, the parenchyma includes the ductal, lobular, alveolar structures. It is composed of the alveolar gland with tree-like ductular branching alveoli. The stroma includes the connective tissue, fat tissue, blood vessels, nerves, and lymphatics. So there you go. Someone else asked about photos. And so if you have a question about photos, you can find it in your handouts. We have several blog posts in our handout. And one of them has to do with photos. And where I go into depth as far as the things that you want to look for regarding photos. Essentially, the first thing I want to say, which I don't believe is in the blog post, is that you will note a lot of whiteness in these images, and they will not be perfect images as the one on the screen that you see right now. And the reason why is because they're clinical pictures, and whenever you go to see a client or you see someone in the hospital, the lighting may not be perfect, right? The people may not be posed perfectly, and they may not be a lot of people of color, which is a phrase that we use here in the United States. And so indeed, instead of being outraged by the lack of diversity in the images, take a look and answer the question. Know that there have been many people who've looked at that image and have been able to answer that question, the corresponding question. And so just be mindful of that. In other words, check your annoyance and answer the question. So you want to take a look at if there's any discoloration in the skin, for example, in the previous question on mastitis. So you want to take a look at color. You also want to take a look at the babies. And you want to see, when you're looking at babies, you're looking at children, you're looking for developmental milestones. Another link on the handouts is a link to the CDC website on different developmental milestones. And so that can be something which is really helpful to review. And the reason why we have that link there, as well as other links on infant growth and development, is that that's usually where most people score poorly, is on infant growth and development. And so if that is something that is challenging for you, then please do take a look at some of those resources. Also, if you, let's say, for example, you work in the community and you don't see many newborns, Stanford University, also in the United States in California, has a newborn photo gallery. And so you can take a look at some of those images and be able to decipher what you're looking at. And so do review what you need to review in order to feel more comfortable and confident taking the exam. Are there any other questions looking here? I do know that many of you are participating from different areas around the world. Someone just said thank you from the Ukraine. And so if you'd like to pop that into the question box prior to saying good day, that would be wonderful. So someone is asking, what is postglandular? So those are things that can impact milk production, which is not related to the glandular tissue itself. So that's going to be pacifier use, unmedically necessary supplementation. So those are all sorts of things which can be considered postglandular. So we have people from the UK, shout out from Oklahoma, howdy y'all. Oh. California, Canada, Ontario,
Canada, yes.
So this is great. And remember that a majority of people pass this exam. A majority of people pass this exam. And if you're sitting the exam at 10 years or 20 years or 30 years, nice.
Panhandle of Texas, California.
Oh, nice.
New Orleans, Louisiana.
Yay. So if you're resitting the exam for the second or third or fourth time, please know that over 90% of you are going to pass the exam if you're retaking the exam and you've been practicing for 10, 20 years. And so remember that most people will pass this exam, and it's not intended to trick you. And so be mindful of that you can find the answer, it will be there. And as Sekeita said before, don't go back and change your answers unless you're like super duper sure that that's it. So.
I see Mississippi, I see Charlottesville, VA. Someone says Madison, Wisconsin, the dairy state. I was just there yesterday. I was just there. Maryland, New Jersey, Romania. Thank you so much from Georgia. And the question is, what about the pass percentage for first timers?
It depends on when it's taken. It depends on if you're taking it in the March-April timeframe or if you're taking it in the September timeframe. It also depends on what your mother tongue is. I will say that most people, I think the pass rate is somewhere around, like most of the people who will pass is around 72 to 76%. of people who sit the exam for the first time are going to pass the exam. So it is a high percentage of people. It's a majority of people are going to pass the exam. And so know that, and it's interesting, the data on different pathways is unique as well as those taking it if they're taking it in English and that's not their mother tongue, or if they're taking it in the language that is their mother tongue. So that can make a difference as well. And so please do, we actually have that we recorded a couple of months ago on how to create a study plan for the IBLCE exam. And so in there, we actually go into the data a little bit more in depth. I don't remember it off the top of my head, but I know if you go to our YouTube page, you'll be able to find it. Okay, great. Well, if there are no other questions, we'll leave it open for another moment or two. If you do have questions, you can contact us, support@lactationtraining.com. And yes, if you want to reach out to me directly, love@lactationtraining.com. And you're more than welcome to email us and to ask questions. For those of you who are our students, if you have, if you took the 95-hour course through us, if you've taken exam review through us, there is a Facebook page that you can join. And so feel free to join that Facebook page. It is moderated by Julie and Kim. Yay, thanks Julie and Kim. And so please do let us know if you have any questions or what we can do to support your journey.
I just have to plug that page though, Angela, because I remember when you told me about it and I'm like, what? There's a what page? And even as someone who had been practicing, because I had to retake my exam after 10 years, but even as someone who has been practicing, can I just say I love Julie, whoever at that time was doing there was a question of the day. I loved getting that question of the day. It also, because not only was it questions, right, but it also taught you a little bit of how to think through the questions. And
Exactly.
when, you know, colleagues and folks were chiming in where I thought this because of this and then other, it was just a great way to prepare for me, you know, and so I recommend that
Right.
for anyone. Absolutely.
Good, good, good. Yes, and indeed we have a new product called QBank, and our LER QBank is something which is really exciting. We have over 400 questions in the QBank. Nice, Pakistan, hello. And so we have over 400 people or 400 questions, and you can actually set up questions and practice. And you can do it in tutor mode, and we give the answers. We don't, you know, you take the test and then you can find the answers. If you didn't get the question right, we explain it and we provide references. And so we're very happy and very excited about that. So please check it out if you would like more questions.
Thank you for those who stuck around. I know this was supposed to be an hour and a half. Angela and I, we just try to give you everything in a way that's real, in a way that you can understand and process. So we try to answer as many questions as we can live. So thank you for sticking around for this. Yeah, because we're here for you all.
Absolutely. This has been super fun.
Yes.
Thank you very much.
Yes, thank you for joining. Good night, good evening, good afternoon, and good morning to some.
Thank you.
Bye-bye.
And you can find the link to the QBank, someone just asked, you can find the link to the QBank on our website, lactationtraining.com, and go to exam review, and there it is.
You'll find
Great.
the link to QBank in your exam review course. So you have to purchase the exam review course, and then in that, there will be the link to QBank.
Thank you so much, Julie. You're absolutely right. Appreciate
Love Julie. Thank you. Thanks, Steve. Thanks, Julie. Thanks,
Kim.
Bye-bye.
Bye-bye.